everyone. We'll go ahead and get started. My name is Juliana Tamayo, and I'm one of the graduate assistants this semester in the Women's Studies and Gender Studies department. Thank you everyone for joining us today. This is our last feminist lecture series event of the semester. We've had amazing guest speakers and an amazing turnout, so it's wonderful to see all of your support each time we present a new topic. If you have any questions during the presentation, please type them out in the chat or send them directly to me, and we will have time at the end to go through those. Again, my name is Juliana, and here's my email. And then if you have any questions about our program, want to know more about the events we're coordinating, or want to know how you can get signed up for our newsletter that goes out every week, just shoot me a quick email and we'll get that set up. Our Instagram is at LUCWSGS. We try to keep that as updated as possible with all of our events, as well as other things happening on campus. So that's always a great tool to have and a great resource. If you are inspired by today's talk and would like to propose a topic for next semester's feminist lecture series, our call for proposals is now open. You can find that on our Instagram page, the link to the registration. And if you want that, again, email me and I'll give that to you. The proposals are due December 2nd. So if you have a topic, a research project, or anything that you think would fit with our theme, please go ahead and propose your topic. Now a little bit about Sue. Sue became interested in medical gaslighting through her work in chronic pain and illness management and through her own personal experiences living with Ehlers-Danlos syndrome. Her primary areas of interest are disability justice, healthcare ethics, and cultural appropriation and third wave behavioral health interventions. Sue, thank you again for sharing your knowledge and your work with us. We're all very excited to have you speak and hear your story. I'll stop sharing so you can go ahead. Oh, you're muted.
I didn't have permission to unmute.
Oh, sorry.
Panicking. All right, give me 1 second to share my screen. All right, thank you everyone for being here today. I'm very excited to be here talking about medical gaslighting. As you might know, this recording or this lecture is being recorded. It will be put up on the event page, as well as hopefully we'll be able to put it on YouTube later. All right, I'd like to start out with some acknowledgements. First of all, it's really important to say that Chicago, where Loyola is based, is on the Three Fires Council land. All of this land was taken from other people, and since medical gaslighting is the topic of this lecture, I feel like it's really important to mention that because Indigenous Americans have experienced gaslighting since the very beginning. I wanted to thank the previous presenters, and then also Marissa Latini and Juliana Tamayo for setting this up for me, and also to the Women's Studies and Gender Studies department, all of my teachers, especially Nora Ishibashi and Elaine Bozar, all of my clients, my classmates and my friends, particularly people who have chronic illnesses and have shared their stories with me, and also thank you to the wonderful disability social media community. Let me tell you a little bit about me. I am excessively thorough and I could not fit the list of all of my resources onto one slide. So if you want to follow along with me, if you go to tiny.cc/medical gaslighting and make sure and capitalize the M and the G, you'll be able to download the lecture slides as well as my full bibliography, and also another bibliography I created about disability in general. So I've been an acupuncturist since 2013. I got interested in acupuncture because I was chronically ill, and acupuncturists were the first people who said to me, wow, I really believe what's happening with you. Because of that, I am an instructor at the acupuncture school, Pacific College of Health and Science. I'm also in my last semester here at Loyola in the social work department, and I'm graduating in December. So if you hear of any jobs, please send them my way. I've been chronically ill since I was in my late teens, and I do identify as disabled, and I have a history of mental illness. And because of that, I also identify as neurodivergent. I have a lot of sensory processing issues, and I definitely feel like the way that my brain is wired is quite different. I'm also queer and agender, which to me means that gender isn't really part of my identity. I use they pronouns or she pronouns, and I'm honestly not bothered if people call me he or him. It's also super important to note that I am white, and because of that, I have white privilege, and I'm also thin. You'll notice I've capitalized white throughout these slides. I will have capitalized white and black because it's really important to know that those are social categories, and the idea that whiteness is not a social category is something that contributes to white supremacy. And, you know, by capitalizing white, we actually help fight against the idea that whiteness is the default and that it's a neutral category. So, a content warning. This lecture will probably make your blood boil. If it doesn't, I'm not doing my job correctly. So we will be talking about racism, sexism, sexual assault, medical violence, body size bias and fat phobia, transphobia, denial of medical care, medical trauma, non-consensual treatment, microaggressive language, and medical and psychiatric misdiagnosis. We'll be talking about diagnostic power. We'll be talking about hysteria and the concept of psychosomatic illness. We'll be talking about biases and physician assessment. We'll be talking about consequences of medical gaslighting, and then finally the ethical considerations and the next steps. I wanted to start by defining a couple concepts that I'm going to repeat over and over just to make sure everybody's got the vocabulary. Psychosomatic means a medical condition that's caused by the mind. Autonomy is being able to make your own decisions, particularly when it comes to your own life. Implicit bias is a hidden preference for a certain group of people, and explicit bias is an open preference for a certain group of people. When we talk about something that's systemic, we're talking about an issue that's created and maintained by society and institutions, whether that's the government, whether that's school, the police. So those are all systemic things. Cisgender and transgender. So if you're cisgender, that means you identify as the gender that you were assigned at birth. And if you're transgender, that means you don't. Finally, a functional diagnosis. So this is a medical diagnosis that's used to describe a group of medically unexplained symptoms, like IBS, which is kind of chronic stomach digestive problems with diarrhea or constipation, vulvodynia, which is a really painful condition that affects the vulva and vagina, and fibromyalgia, which is kind of whole body pain that doesn't seem to have a specific cause. So I thought the best way to introduce the idea of medical gaslighting was by giving you a story about somebody you might actually have heard of. So we have here a picture of Serena Williams, who is a very fit, athletic Black woman. And here she's standing in front of a tennis net, holding a tennis racket and crouched over a little bit as if she's about to serve or hit the ball. Serena Williams had a baby a couple years ago. And before that, she had had a history of blood clots forming in her legs and moving into her lungs. And because of that, she'd had to take blood thinners for quite a long time. But while you're pregnant, especially towards the end of pregnancy, it's not safe to take blood thinners. And then she had to have a C-section. And shortly after having the C-section, I think the next day, she started having shortness of breath and chest pain. And she said to herself right away, oh my God, I have blood clots in my lungs again. And so she pulled a nurse over immediately, said, I have blood clots in my lungs. I'm having shortness of breath. You have to put me on blood thinners right away. You have to do a CT scan of my chest. I'm going to die. You have to do this. And the nurse immediately said, oh, you know, I bet she's confused because of her pain meds. And Serena said, you have to scan my chest. I'm going to die. And she kept insisting and she kept insisting. And finally, a doctor came in and said, okay, we'll ultrasound your legs to humor you. And so they ultrasounded her legs and they didn't find anything. And Serena said, you have to scan my chest. I'm going to die. And surprise, surprise, they did a CT scan and they found a whole bunch of little blood clots in her lungs, which could have killed her. And the reason I tell you the story is because Black mothers and other people who give birth are 243% more likely than white to die in childbirth. And that, I believe, is a consequence of this medical gaslighting. So medical gaslighting, this is from a paper that I wrote that's currently under review for publication. Medical gaslighting is the repeated denial of a healthcare service user's testimony in which the clinician expresses doubts about the truthfulness or the reliability of the client's claims, frequently offering instead a psychological explanation for the client's symptoms, or else maybe saying, that's just not what happened to you. Medical gaslighting is highly correlated with gender and skin color or ethnicity, and it has ramifications such as delays in diagnosis and appropriate care, non-consensual psychiatric treatment, and the development of internalized ableism. So medical gaslighting is a form of injustice that's specifically called epistemic injustice. Epistemic means having to do with knowledge. And so, an epistemic injustice, according to a feminist writer called Miranda Fricker, epistemic injustice wrongs the individual by calling into question their ability to tell the truth, to describe accurately their experiences. A subcategory then of epistemic injustice is testimonial injustice. And that's what happens when we don't believe people because they're part of a specific group. And here's the thing, testimonial injustice makes people mad. It upsets them. It makes them become emotional. And then what happens? People say, oh, well, this is further proof that you are unreliable because you're so emotional. And so what this does is it creates a deficit in their credibility. And this essentially has set up the conditions for medical professionals to see certain groups of people as unreliable, as well as being responsible for their symptoms and being unable to accurately tell the truth of what they're experiencing. And the reason we're talking about this today is because medical gaslighting is an intersectional issue. So by intersectional, I mean that it affects people who have overlapping identities, people whose identities intersect. So people who are Black and disabled, people who are Black and transgender, people who are white and queer and fat and disabled. There's all these overlapping identities, and the more identities you hold, the more likely it is that you experience medical gaslighting. Well, now let's move on to talking about physician assessment. So the whole thing about psychosomatic illness is that they tell you it's all in your head. So sure, it's in someone's head, but whose head is this actually in? This is a cartoon here on the left from the New Yorker, and it's got an old grumpy looking white man sitting in a chaise longue facing away from another white guy who's in an armchair, and it looks like he's the psychiatrist. And underneath it, the caption says, when a psychiatrist says it, it's not considered psychobabble. So the thing about psychiatry is that it's the only field in which the body is absent. That's a quote from Michel Foucault, who's a philosopher who talks about the way that society constructs categories like race and gender and ideas in general by agreement. So ideas become true because people agree on them. And so Foucault said that the difference between psychiatric diagnosis and biomedical diagnosis is because psychiatric diagnosis is absolute. It's invisible. The power is 100% in the hands of the clinician. There's no lab test that says, oh, you have schizophrenia, you have a psychosomatic condition. The doctor alone has the power to say you're mentally ill. So the way that happens is that the people that outline the criteria for diagnosis, the American Psychiatric Association, they get to define the terms of reality. And then the patient who comes in, they look at their group of symptoms, their presentation, and they say, does this match reality? And if it doesn't, boom, you're mentally ill. And the way that this is achieved is because the patient comes in and surrenders their power, their testimonial authority, their ability to say, I can tell the truth about my reality, and I can state with certainty what I'm experiencing. And then once this happens, once you receive a psychiatric diagnosis, the burden of proof is forever upon you, the patient, to prove that it's not all in your head, that your condition isn't psychiatric. So let's go back to the last century, not 2 centuries ago, and look at hysteria and Freud and psychosomatic illness. So the whole concept of hysteria kind of comes from this 19th century early psychiatry this thing where they thought that women who came in and had these inexplicable symptoms like loss of speech, fatigue, body weakness, convulsions, hallucinations, body pain, fevers, agitation, and they decided that this was caused by repressed feelings, particularly those that come from their uterus. The word hysteria comes from uterus. Once you fast forward to the 20th century, you had these feminist critics who came along and said, listen, this is the result of a patriarchal society that did not let women make their own decisions. So of course their bodies were acting up. But here's the thing, they didn't have MRIs, they didn't have lab work. So something like multiple sclerosis that causes coming and going symptoms like weakness and fevers could very easily have explained these hysterical women. So a lot of the early concept of psychosomatic illness and hysteria comes from Freud, who I think hopefully all of us have heard of Freud. He was a Viennese psychoanalyst. He was a doctor, and then he decided to become a psychoanalyst. And one of his most famous cases, and his most famous example of hysteria, was called Dora. It was a heavily fictionalized story about a 14-year-old girl whose family brought her to him for treatment. She was experiencing a loss of voice, no desire to speak, a chronic cough, a little bit of a limp. And they brought her to Freud, and it turned out that what had happened is that her father was having an affair with a woman, and her husband was attempting to groom Dora. He was giving her inappropriate presents. He was sending her romantic letters. He was, at one point, she was left alone by her family with this older man who physically accosted her and groped her. And so then afterwards, when she kind of retreated inward into herself and possibly also maybe got sick from the stress to her body, they took her to Freud. And Freud ignored her story and said, listen, I know what's happening to you, and it's that you liked it. You got turned on when this guy, Herr K, groped you. You were so aroused and you were so unable to accept that you were turned on that the desire ran up from your clitoris into your lungs and repressed your voice. This is a perfect example of a male doctor ignoring a woman's testimony and then redefining her reality to match his interpretation. So when Freud wrote the story of Dora up, he changed a lot. He made her older. He didn't really talk about how horribly inappropriate it was that they left her alone. And it was essentially autobiographical fan fiction. And so when this was first published, everybody said, this is mental masturbation. And yet later, going into the 50s and 60s, we had all kinds of people that are like, yes, let's base all of our concepts of psychosomatic illness on Dora, on this idea that sexual desire and frustration cause physical symptoms. So let's fast forward to 2013 or so. The APA, who are the people who hold the power to determine what is and what isn't mental illness, because the codes that they assign to each definition of a mental illness is required for insurance reimbursement. You have to use the DSM, the Diagnostic and Statistical Manual, to get paid for treating a mental illness. And so the DSM-5 defines somatic symptom disorder, hysteria, psychosomatic illness, by saying you have a single body symptom, but the main thing is that you're devoting too much time to thinking about it, to having feelings about it, or to taking care of your illness. One symptom, and you're worrying about it too much. And so Dr. Alan Francis, who was actually the task force chair of the previous edition, wrote all kinds of editorials when this book came out. And he said, this is not okay. The amount of funding by pharmaceutical companies that's going into this book is utterly corrupt. And the fact that you have loosened the requirements from previously being 8 symptoms that are completely medically unexplained to one body symptom that can actually have a medical cause that's well known, this is going to cause problems. This is going to cause 25% of chronic pain patients and 1 out of 6 people who have cancer, 1 out of 6 people who have heart disease to get diagnosed with psychosomatic illness. This could lead to a false positive rate of 7%. And so this doesn't even include all the people whose doctors have dismissed their symptoms as stress. So whose head is this really all in? If the sole criterion for diagnosing somatic symptom disorder is that your doctor thinks you're paying too much attention to your illness, what could be influencing the doctor? Well, there's racial bias. So Harvard has created this wonderful instrument called the implicit assumption test. There's a link to it on the last slide of my presentation. And it's an online test. And what it does is it shows you pictures and it has you sort them left and right key. This is a good picture. This is a bad picture. Or it might have you sort a word. This word goes with good and this word goes with bad. And then halfway through, it'll switch and it'll say, okay, now take this picture and say whether they're white or black. And then they go back and ask you, is this good or bad again? And they can determine by looking at the way that you hesitate before you pick good or bad, whether or not that you have a bias or preference for white or black or fat or skinny or Arabic or non-Arabic. They have a whole lot of categories. And this is an extremely well scientifically validated test. And they have done so many tests that there's now, a good 15 or so studies where people have gone back and reviewed thousands of tests. And shocker, over and over, white physicians have a preference for white patients. Physicians of color who are not Black also tend to have a preference for white patients. Only Black physicians did not have an implicit preference for white patients. And so one of the things that this is correlated with is with doctors perceiving white patients as being more compliant with treatment, as well as with Black patients walking out of the room and saying, that doctor was terrible, low satisfaction. And then this is a relatively shocking study. Back in 2015, the National Academy of Science presented the findings of a survey that indicated that up to about half of medical students or residents that they interviewed held the false belief that people with Black or dark skin felt less pain, that they had thicker skin just because they had more pigment in their skin, that they had less nerve endings, that they healed faster, that their bodies were tougher. Physicians also have, for centuries, perpetuated false beliefs about Indigenous Americans, for example, that they have a genetic predisposition for alcoholism. Not true at all. More implicit assumption research from Harvard shows that physicians really, really consistently are not even ashamed to report explicit anti-fat bias. So it's not just that they secretly had these beliefs about people who are fat. These physicians were open and willing to say things like, fat people are worthless, fat people are lazy, they're weak-willed, they're bad, and they're a waste of time. And honestly, I don't even like to read these things out loud. This is extremely troubling because BMI is based on Scandinavian men. It's not an actual real measure that is valid in any way. The idea that body sizes should all look the same when there's such an evident and obvious difference in body shapes and sizes based on geographical origin. People that live in the Andes in South America, people that live in the Pacific Islands, people from Siberia, people from France, they all have different shaped bodies because of the regions that their people kind of evolved in. There's also no evidence at all that high BMI is unhealthy. It does not directly cause poor health. You can be fat and you can be healthy. The issues that come along with being fat are more likely to be caused by lack of access to good nutrition, lack of access to exercise, the impact on your heart of sustained trauma, generational trauma that causes genetic changes in your ability to metabolize things, not to mention the sustained stress of fat phobia, of people constantly criticizing your body and constantly hearing people say terrible things about bodies. And so when I was preparing for this lecture, I ended up reading this really fascinating article by Dr. Sabrina Strings that was called "Obese Black Women as Social Deadweight: Reinventing the Diseased Black Woman." And her point was essentially that by equating high BMI with people of color, and then by taking that and saying, you know, Black women ignore medical advice, fat Black women, they just engage in risky behavior. What we're doing here is we're actually perpetuating views of people of color as deviant and morally deficient, as being weak-willed. There's also an incredible amount of research showing that there are gendered expectations from physicians. So a Swedish team of researchers reviewed 77 articles about chronic pain and gender from the US, Canada, Western Europe, Australia, and New Zealand. And they looked at research about pain and gender that included back pain, neck pain, musculoskeletal pain, fibromyalgia, osteoporosis, rheumatoid arthritis. And they found over and over and over gendered expectations about behavior of people in pain. So men are expected to be stoic or tough. They're expected to be brave. They're not supposed to show weakness. They're not even supposed to slow down. Doctors don't tell men to slow down, to stop doing activities. And one of the reasons, maybe because the reason for that, is that chronic pain is associated with a loss of masculinity and strength, not just by providers, but by patients. On the other hand, women are viewed as being more sensitive to pain, hysterical, emotional, complaining, not wanting to get better, faking it for attention, and women are more likely to be told to just accept their diagnosis, to just accept their symptoms, just work less, give up your fun activities, adjust your life and get used to it. When women had medically unexplained symptoms, doctors are less willing to believe them, and they're more likely to give psychological or psychiatric explanations. There's also a profound cisnormative bias in medicine. So a cisnormative bias means a preference for cisgender people, or viewing being cis as the default, as being normal. We see this in a survey from a research article called "Transgender Care by Endocrinologists in the United States" that was from 2016. And 74% of the endocrinologists that they surveyed were not competent, or were only a little bit confident in providing transgender care. And the problem with that is that you have to go to an endocrinologist, by and large, to get hormones. Only 20% of these doctors felt comfortable discussing gender identity. So outside of large cities, it's very difficult for them to find care. Trans people also frequently have to educate doctors about what it means for them to be trans. And in return, they're met with things like consistently being misgendered, being called he when their pronouns are she or her, or by providers actually just expressing disgust about them. You know, you walk by the nurse's station and they're like, "Ugh, is that even a man? What is that even a woman?" You know, and on top of this, physicians continuously discredit non-binary identities, so they just can't even wrap their heads around it. On top of this, if you're transgender and you want your insurance to pay for treatment, you have to use the diagnosis gender dysphoria, which is technically a mental illness. So if you're trans, you're more or less forced to say that you're mentally ill in order for your insurance to pay for treatment. On top of this, this also affects people who are intersex, meaning that they're born with characteristics that are historically viewed as both male and female. One of the more famous stories is the story of a local Chicagoan named Pigeon Pagonis, whose activism actually recently convinced Lurie Children's Hospital to stop doing surgeries on children. But children with intersex characteristics are frequently subjected to non-consensual genital surgeries at a very young age just to make their genitals look normal because their parents were feeling anxious about it. And then after this, they're subjected to frequent exams by strangers, you know, a room full of doctors, a room full of medical students, and you're a 6-year-old in there all looking at your genitals. And then after that, you know, a lot of your childhood, no one even tells you what's going on with you. So those are the things that cisnormative bias causes in our medicine. We also see this really kind of unfounded insistence on medical explanation. So physicians view patients who have medically unexplained symptoms or functional diagnoses like fibromyalgia or IBS, chronic fatigue syndrome, environmental sensitivities, mast cell activation syndrome, all these different more like rare conditions that people don't, you know, have an exact explanation for. They think because there's no exact explanation for their symptom that they're faking it for attention. They're responsible for their pain, and they don't want to spend time with them because they're so time consuming and they're so frustrating. And all these studies about medically unexplained symptoms consistently focus on the absence of evidence instead of the presence of their pain. The burden is on the patient. And the reality is that this reliance on medical evidence is completely unjustified. There is no direct relationship between actual disability and pain and medical evidence. You also see, especially within people who have fibromyalgia, that they think of fibromyalgia as not a real diagnosis. They think of fibromyalgia as being this code word that doctors use for psychosomatic when they just don't want to say it to your face. And this is despite the fact that there is so much research showing that people with fibromyalgia have physical abnormalities in their body. And I could spend an hour just talking about fibro. We also see from a research article called The Hidden Marginalization of People with Environmental Sensitivities. So people who are really sensitive to fragrances, to outgassing from paint, to even like people who get sick from glues and carpets and things like that. They get sick building syndrome. Most of them initially were told that they were mentally ill. 41% of people who have vulvodynia, which is really like stabbing pain in the vulva and vagina, 41% of them were initially given a diagnosis of mental illness. And the thing is, once you get the psych explanation, it is impossible to get past it. We also see stereotypical views of disability. So physicians tend to significantly underestimate the quality of life of people with severe medical conditions, people who need to use ventilators, people who have feeding tubes, people who are on oxygen. And so by framing these types of medical interventions as heroic efforts or special needs, this contributes to the perception that this indicates that they have a quality of life that's really terrible. We think, oh, I would kill myself if I ever ended up like that. That's so harmful, because when we say this isn't standard treatment, we're saying this is extra, you're special, you're lucky to get this. Disabled people are often seen as heroic, inspiring, brave, but then we also see them as asexual, childlike, incompetent, not able to take care of themselves. This creates this sort of model cripple ideal. And so people who don't fit into this mold, people who are assertive, people who have a lot of sex, even though they're in a wheelchair, they're viewed as complaining, unreasonable, risk-taking, non-compliant. All right, so we proved that maybe it's all in someone's head, that's not just the patient's. What actually happens when it's all maybe in the doctor's head instead of the patient's? So we see from the beginning inadequate treatment, diagnostic delays. This country was founded on germ warfare. We have centuries of Native American, indigenous people being taken away from their families, sent to schools, forcibly sterilized, Slavery, people were sterilized. Scientific justifications for slavery, for segregation, for Jim Crow. We had the Tuskegee syphilis experiments in which several hundred Black men were told, oh yes, we're going to do medical research on you and give you excellent care. And instead they let men who had gotten syphilis, they just watched them and didn't give them any treatment and told them they would take care of them just to see what would happen. And so the consequence of these decades of medical maltreatment, we see that, Black women experience severe maternal mortality at a rate 240% that of white women. Women who are Hispanic or Latinx, or other people who give birth who are Hispanic and Latinx, also experience higher severe maternal mortality, higher rates of dying right after childbirth. Just in New York City hospitals, 30% higher chance of dying. Black people in general experience delays in diagnosing heart conditions and clotting disorders, particularly women. Black women have much longer delays in getting diagnosed with breast cancer. Women across the board, regardless of gender, experience really long delays in diagnosis of endometriosis, which is a condition in which the lining of the uterus actually grows outside of the uterus and it sticks to the diaphragm, to the intestines. It causes scars and it's excruciatingly painful. But because the standard is to insist on poking a hole in your stomach and doing surgery to make sure it's there, which has a 6-week recovery, most of these people have up to an 11-year wait to get diagnosed because doctors say if we can't see it in person, it's not real. Even more troubling, research from the Reasons for Geographical and Racial Differences in Stroke study, where they surveyed several hundred people who were who had been diagnosed with atrial fibrillation, which is a heart condition that causes irregular heartbeat. They were way less likely to be aware of their diagnosis, and they weren't even on blood thinners. So they were only a quarter as likely to be taking blood thinners, which prevents strokes. On top of this, you see that when Black people or people who are Hispanic or Latinx go to the ER and they have broken bones or open wounds, they consistently receive less pain medication than white people, even when the doctor accurately assesses their pain. And we see extremely evidently, particularly in Chicago, the enduring effects of these treatment disparities. So here in Chicago, 60% of the COVID cases are Black. And that's from decades of not only systemic inequalities, but this medical gaslighting where people are not getting diagnosed with heart conditions because they're just stressed out. Oh, you're just an angry Black person. There's also very serious consequences of fat shaming, of weight stigma. People experience fat shaming, immediately eat more afterwards, and then their body produces higher levels of cortisone, which is a hormone that contributes to body fat formation. All kinds of different body chemicals that affect your metabolism directly increase when you are made fun of or when you're bothered about your weight. If this is compounded by racial stressors, then it really significantly increases it even more. So a study of almost 17,000 people, the Health and Retirement Survey plus the Midlife in the US survey that studied thousands of older adults, found that people who experienced weight stigma throughout their life had a 60% chance higher of dying independent of their BMI. So it didn't even matter what their BMI was, 60% higher chance of dying. So physicians also spend less time with people who have higher BMI. They just don't want to be around patients they think are fat. They do less health education, so they don't talk to them about their health. They don't talk to them about nutrition or about exercise or about mental health. They also do less pelvic exams, so there's less cancer screenings happening. They also overlook disordered eating, especially anorexia. So for insurance to pay for anorexia treatment, you have to have a certain BMI. And so if you're too fat, then you just don't get treated for your eating disorder. There are also so many horror stories of people being told to lose weight for years before receiving a cancer diagnosis. There's a young woman named Rebecca Hiles who started coughing up blood at age 18, shortness of breath, went to doctor after doctor after doctor. And it was not until she was 23 years old that they finally did a CT and said, oh, half your lung is rotten. it is cancer. Oh my gosh, we're sorry. And I will freely admit that, like, my field, integrative medicine, is not blameless either. There are so many people who experience blaming and shaming from acupuncturists, from body workers, from integrative nutritionists. Chronic and rare diseases are highly, highly, highly correlated with psychiatric misdiagnosis. So not only are women more likely to receive a psychological explanation for their pain, but people who have chronic, particularly like invisible diseases that aren't necessarily immediately obvious. A survey from the American Autoimmune Related Disease Association found that 45% of people who had autoimmune conditions, so conditions where your immune system starts to eat your own body, basically, 45% of them had been denied medical care. They'd gone in to say, please help me with this chronic pain. The doctor said, nah, it's all in your head. A survey of 12,000 European patients who had rare diseases, meaning 5 in 10,000 people have it, found that 41% of people who had these rare diseases initially received a psych misdiagnosis. 7% received inappropriate psychiatric treatment as a result. And people who received that initial psych diagnosis often had more than double the delay of those without. So people with Crohn's disease, which attacks the intestines, typical diagnosis can take about a year. With the psych diagnosis, 6 years. Ehlers-Danlos syndrome, which is what I have, it causes stretchiness of the joints. It causes all kinds of systemic issues, makes your joints pop in and out of place, and really just your whole body hurts. Usually takes 16 years to diagnose. If you have a misdiagnosis, 22 years. Overall, of these 12,000 people, they found that if they got a psych explanation first, between 2.5 times longer and 14 times longer. This is very consistent with my own experience. I was diagnosed with fibromyalgia when I was 24, and I didn't get diagnosed with Ehlers-Danlos syndrome until 2 years ago when I dislocated my hip putting on my pajamas. And the very first orthopedic doctor that I went to said, that didn't happen. You probably felt the tendon from your hip muscle just rub over the front of your pelvis. You're wrong about what happened to you. And because of that, it took 8 months for me to have surgery. And it turned out that I had ripped the entire front third of my hip socket loose and been walking around on it for 8 months because, and I believe this is what happened, he looked at my medical records, he looked in my chart and he saw, oh, Sue has PTSD and fibromyalgia, all in Sue's head. And when a patient comes up with a diagnosis themselves, or someone else, maybe a family member or a friend says, oh, maybe you have Crohn's, maybe you have EDS, maybe you have, Duchenne's muscular dystrophy. Like there's so much evidence that it can delay the diagnosis up to, again, twice as long. So 12 months for Crohn's versus 30 months. EDS, 156 months versus 227 months. And 58% of people who had EDS reported consulting more than 5 doctors. 20% of us more than 20 doctors. Finally, I think one of the most overlooked consequences of medical gaslighting is the psychological harm. So a lot of doctors have this belief that if you validate chronic pain and medically unexplained symptoms, that it'll make the patient associate focusing on their pain with acceptance. And so they'll need acceptance over and over again. And the reality is that validation doesn't change pain tolerance. They've done all kinds of research where they, poked you with needles while you got yelled at, or they studied nurses with low back pain. And they showed over and over again that invalidation makes your mood worse. It makes you more worried. It makes you hate your doctor. I know, shocking, right? Research on the nocebo effect, which is the opposite of the placebo effect. So nocebo effect is the negative effects that are caused by a treatment or a doctor. This research shows that even little things like observing your doctor's body language and the way they talk to you can actually change how well the treatment works. So that means you can have things like more side effects, like if your doctor is mean to you and makes you feel like garbage, your meds might not work as well. And you'll also maybe have less confidence in actually following your doctor's recommendations. And then finally, invalidation causes internalized ableism. Maybe I deserve this. Maybe I am faking it. Maybe I am crazy. Maybe there's something really wrong with me and I am not good enough because I'm sick and nobody knows why. Research where they go and do in-depth interviews with people who have invisible disabilities, all kinds of chronic illnesses, show that they over and over say, I'm not good enough. I have to prove that I'm okay. Like I have to constantly justify my existence. And this is definitely true of people with fibromyalgia. As an acupuncturist, as well as somebody who worked at a medical cannabis dispensary, over and over, people I talked to with fibromyalgia were like, fibro, with quote marks around it, because they don't necessarily even feel like that's a real doctor because of the way their own doctors treat them for having fibromyalgia. All right. Okay, I know, I'm sorry, so I'm like 5 minutes over my time, but I promise we'll have time for questions after this. So what do we do? What do we do about this? We have to uphold and we have to promote codes of ethics for practitioners that value the patient's and client's right to autonomy and dignity. So the social workers code of ethics, the psychologist code of ethics says you must support the client's right to dignity, to autonomy. We should extend this to MDs. And if you're a provider, if you're an MD, I encourage you to practice humility in the face of uncertainty. I sent my doctor a message about this talk and I was trying to convince her to watch. And she said, well, what do I do if I have a patient where they have chronic symptoms and I can't explain it? I said, you tell them that. You say, gosh, I feel so bad that I can't explain, what's going on with you, but I want you to know that I believe what you're experiencing is real. And I love this quote. This is from Diane O'Leary, who's a bioethicist. And she says, our understanding of autonomy suggests that it's problematic to imagine that physicians can authoritatively determine and productively assert that patients are mistaken in their experience of biological illness. There's no justification for telling someone, I'm sorry, you're wrong about what you think is happening to you. We need to only give psychiatric and psychological treatment or referrals when someone has consented to it. If someone comes in to go to the doctor for a physical concern and you give them a referral for cognitive behavioral therapy, they did not consent to that. How do we stop this from happening? We need to go to the bottom. We need to start with changes in how we educate providers. We need to change med schools. We need to not only diversify the student body, but the admissions committees, the administration, the professors. We need to teach a client-centered model. We need to look at people in the context of their lives. We need to say, okay, yes, I know I have to put this code on here for insurance billing, but maybe diagnosis isn't all that. Maybe the DSM isn't all that. And then I think this is most important. We need to make classes in these medical training programs, in these practitioner training programs. Right now, most of these programs, disability classes about the LGBTQ community, these are electives. Classes about racism, these are electives. These need to be core requirements. The rallying cry of the disability community is nothing for us without us. And so we need to extend that to all these identities and say we need research that is led by people of color, education led by people of color, by disabled people, by people who are trans and gender nonconforming, or by people who hold multiple identities. We need to challenge social stereotypes of race, gender, disability, and size. And then we need to participate in activism and seek out our community. Even if you're alone, you can find a community online. Just check out disability Twitter, check out disability Instagram. They're amazing. And also leaving that detailed review of your experience for your doctor, whether they're good or bad, that helps other people who have the same conditions that you do. So in conclusion, and I know that was so much information, so thank you so much for staying with me. Medical gaslighting is extremely pervasive in healthcare. It's the result of decades of biases about race and gender, and this has created differences in treatment. Our system has created this deep chasm between providers and patients, and it's this deep gap where we just view people with medically unexplained symptoms as crazy, as responsible for their pain. And so we have to address this through changing the system. All right, thanks so much for bearing with me. we'll do Q&A now. My email is sue.e.cook@gmail.com. And again, all of these resources are here for you. Feel free to email me also if you have questions and I can't get to them, because I know I'm a little bit over my time limit. But all right, I'm going to keep my screen shared so that it'll stay captioned. But let's go ahead and take questions. Let me see if I can look at the chat.
If anyone has a question, you can also raise your hand, and then I'll call on you.
All right. I'm not sure if there's any questions, but I did get asked if this would be available. So I do believe that this is going to get recorded, and I'm going to try to put this on YouTube so that everybody who wasn't able to attend the presentation will be able to watch it later. But we also, I think, will be hosting it on the event page.
Yeah, this will be up on the
Okay.
LUC website.
Yeah, so it'll be up on the Women's and Gender Studies website. Okay, so here's a good question. Does medical self-advocacy reduce medical gaslighting? So if you remember when we talked about diagnostic delays, the European Rare Disease Council found, so if the patient themselves or if someone else who's not a healthcare researcher suggested the diagnosis, that actually causes a delay in diagnosis. So in some ways, it may actually, sticking up for yourself might actually cause a delay in diagnosis, which is kind of messed up, right? Like you think that self-advocacy would help, but there's this real change. Okay, Dr. Grossman's got a question. Go ahead.
Okay, thank you, Sue. I have sort of more of a comment or a thought in what you were presenting, which was, you know, thinking about why doctors do this. I mean, and somebody else, I think Jenny wrote about, you know, be interested in knowing more about how to educate our doctors, and just sort of following up on that or thinking about that. I mean, I think, you know, doctors are trained to find solutions, right? They're trained to like say, this is what's wrong with you. And it's almost like, I wonder if they feel like, you know, if they can't come up with a diagnosis, they failed in some way, right? I mean, your comment about what you said to your own doctor about telling people like, I don't know, right? And they're not trained to do that. So I guess my thoughts are, I'd be interested in your thoughts about what we're doing wrong in medical education, and how, I mean, all doctors should be forced to watch your presentation from my point of view, but it's like, you know, what could we do differently in terms of training doctors? Because, you know, we also expect our doctors to come up with the answers, right? So I think sometimes we are culpable in that process, meaning it's sort of a joint hysteria, a joint delusion, right? We as patients believe our doctors should have the answers, and then our doctors then believe they should have the answers, and it becomes this circular logic. So how do we address that? And that's a big question, Sue, and you don't have to know that, you know, you don't have to answer it. It's just more of a thought piece, I guess.
No, I actually think that the current generation of med students are getting more client-centered training. And I say this because for the class that I'm teaching over at Pacific, I actually used a whole lecture series that was designed by Feinberg School of Medicine about racism in healthcare. And it's a very client-centered model. And so, and my cousin just finished med school maybe just a handful of years ago. And just from talking to her, my understanding really is that the current generation of doctors are getting more training in client-centered care, in being a little bit less, you know, ego-driven. And so I do think it is definitely a generational thing. And I think it is very much tied into that, you know, doctors are trained to say, I have to give you an answer. I have to give you medication. I have to give you a treatment. It's unacceptable for me not to know. I think there's also, I think the opiate quote epidemic has a lot to do with it. Doctors are terrified of overprescribing and getting sued for that or losing their licenses. And so people are kind of under treating pain because they're so worried that people are just faking it because they want pain pills. And so I think that these are all like the questions that I have for further research, which are very much like, what causes this? And I think I had a really interesting conversation with an allergist from Instagram last week about this, and she said that really it's very much that physicians are not trained in this, and that there may even be a link between burnout and medical gaslighting, because physicians are so overworked, and they're so it's like the med student life, the resident life, it's just obscene, like working 80 hours a week, like that's normal and safe and healthy for anybody. And then how does that relate to medical gaslighting? How does this cause doctors to become detached from their patients? How do they start to resent their patients? How do they become depersonalized? So that's a great question for further research that I think should be led by physicians. We need MDs to sit down and interview other MDs and say, hey, why are we doing this? Are you burned out? Like, what's the relationship between burnout and thinking all your patients are crazy?
Mm-hmm. Yeah, that's a really interesting question, for sure.
Let's see, I've got another question about research about Latinx women in Latin America. I think there probably is a lot of research. So the study about vulvodynia, for example, that I used was actually conducted from Brazil. And so it was a review of quite a lot of studies that were Latin American. I could certainly, if you give me a couple of days, like I could do some more research and poke around and email it to you. Jenny, if you want some more research leads, I could definitely see if I can send you some articles. Let's see. I think it's interesting, this question about how has COVID changed the treatment of people with chronic illnesses. Early on in COVID, we saw people with chronic, especially like very higher level chronic illnesses, getting turned away from ERs. Your needs are too great. You already have a ventilator. We can't provide care for you. Or they were making decisions, like they were rationing supplies to ventilators based on your quote likeliness to survive. So basically, the sicker you are as your baseline, the less likely you are to get equal treatment in COVID, particularly if you're in a region where the hospitals are already overburdened. So that's one thing. I think that also a lot of people with chronic illnesses are forgoing regular care. A lot of people are not going to their PT, they're not going to their pain management. Paula, if you go to, here, let me click through to there. If you go through to tiny.cc/medical gaslighting with the M and the G capitalized, there's a link to there's like a 5-page list of all the research that I used. And you can get this. Let's see. Thank you, Taylor, for your comments. Yeah, I definitely think that like changes in education, and I'm applying to a PhD in health science research and hoping to like get involved in changing provider education by doing research about this. So I'm certainly hoping that I can be part of helping to change things. But let's see. I know it's around 7. So if anybody has any really pressing questions, otherwise I really encourage y'all to check out this link. I've got a whole bunch more research. I've got all my slides. And then, like I said, feel free to email me at any point, and keep checking for articles about medical gaslighting. Hopefully mine will get published soon. But all right, I think that's it.
Thank you everyone for joining us, and thank you, Sue, again for sharing all of your knowledge and your research. It was a pleasure having you close off our feminist lecture series this year. Again, this recording will be available next week on our WSGS LUC website. And then I believe Sue will also have a copy of it and post it on YouTube. Follow us on social media, stay up to date on our website for future events. And if you guys want to present or if you have a proposal, please let me know, email me, and we can talk about that. Thank you everyone for